Good evening, everyone, and thank you for joining us for tonight's program, Addressing Autism Inequities with the Breaking the Cycle of Autism Disparities group. My name is Siobhan Alvarez, and I'm the Executive Director of the Atlanta Autism Consortium. If this is your first time joining one of our programs, welcome. We are a nonprofit organization dedicated to creating collaborative connections throughout the Metro Atlanta autism community. We host free programs and events every month and aim to serve the spectrum at large, including parents and family members, adults with autism, researchers, clinicians, and educators. Before we get started, a few housekeeping notes. Please know that if you're an attendee tonight, your microphone will remain muted, but you can feel free to ask any questions throughout the event by typing them into the chat box, which is located at the bottom of your screen. After the presentation, we will also have a Q&A session to wrap up the night with our panel. You will also receive an email after the presentation tomorrow that will be shared with all the contact information for our panelists in case you have any questions you'd like to reach out to them directly with. This evening, we are joined by Teal Benavides, Susan Brasher, Samuel Fernandez Carriba, Karen Guerrera, Jennifer Singh, Jennifer Staplewax, and Dr. Leslie Rubin, who will also be serving as our moderator. I'd like to turn things over now to Dr. Celine Salmier, who is actually the chair of the Atlanta Autism Board of Directors.
Hi, everyone. It is such a pleasure to be here and be a part of this Break the Cycle of Autism Disparities group. This is a panel of experts that's bar none, and I'm just so thrilled that they've taken the time to present for you here. So without further ado, I want to send it over to Dr. Leslie Rubin, who is going to be moderating tonight's panel.
Thanks, Celine. Leslie Rubin here. I'm a pediatrician and work with children on the autism spectrum. And it's a great pleasure for me to be the moderator of this auspicious group with all their research activities, and I hope you will enjoy their presentations. The first section of presentations is going to be entitled Implications of Racial and Ethnic Disparities on Health and Health Outcomes of Autistic Individuals. And the first presenter will be Susan Brasher. Dr. Susan Brasher, PhD, is Assistant Professor in the Nell Hodgson Woodruff School of Nursing at Emory University. Susan, you're on.
Great, thank you. And I'm going to be sharing this with Dr. Jennifer Staplewax and Karen Guerra as well. So I'll share my screen and get started. Okay, so as you mentioned, we're going to be talking about racial and ethnic disparities in autism and the implications that has for health and health outcomes. And I'm Dr. Susan Brasher from Emory University School of Nursing. And I'm joined today with Dr. Jennifer Staplewax and Karen Guerra, if you want to say hi.
Hi there, everyone. Glad to be here with you.
Hola, how's everybody doing? Thanks for joining us.
And so this is a little bit about who we are, representing Karen and Jennifer at Children's and Marcus and Emory School of Medicine, and I'm at the School of Nursing. So first, we just wanted to give you a disclaimer for today's presentation is that our emphasis today is going to be on Black and/or Latinx autistic individuals, representing those ethnic and racial disparities encountered by those groups or individuals. But there are many more races and ethnicities outside of Black and/or Latinx that are encountering inequities in access to autism diagnosis and support and services. So we want to acknowledge that there are many other populations that are as impacted, if not more, but the emphasis today, because of the way the research is driven, and we'll talk about why Black and/or Latinx today, but this is where we'll be emphasizing our focus today. So I really appreciated this picture actually that Jennifer Singh shared with us to really represent graphically the structural inequities and what does structural inequities mean. And so I think it really graphically shows here that on a person's individual pathway to health, some individuals have no barriers or challenges and skate right through, or in this picture, run right through and are going to achieve good health and good health outcomes. And other individuals are, as you can see, this one someone's carrying a boulder and had to go over these barriers here. And so the pathway to health and health outcomes looks very different for certain races and or ethnicities. And you could see some have many more challenges, and that does have an impact on their health and their health outcomes. And so this is where we'll talk about the structural inequities and how some of these structures can be these barriers and can lead to poor health or health outcomes for certain particular groups. And so being as my background is in nursing and healthcare as a nurse practitioner, a lot of the emphasis is the impact these inequities has on health and health outcomes. And I think it's important for us to also acknowledge that individuals on the autism spectrum have several co-occurring medical and psychiatric conditions. And so I wanted to highlight, just so that we're understanding some of these co-occurring conditions they're encountering and how these barriers then can lead to poor health outcomes in these areas. So it's estimated that over 95% of individuals on the autism spectrum have at least one of the following, and that's seizures, gastrointestinal disorders, sleep disorders, depression, OCD, anxiety, bipolar disorder, and ADHD. And so several co-occurring conditions. So if we think about some of those barriers that some of these families and individuals are going to encounter and that how that can lead to poor health outcomes, these are some of the conditions in which that are co-occurring within autism. And so I also just want to level set some of the words that we're using tonight when we talk about equity and what does that mean, and inequitable. And so we'll talk a little bit on the next slide about that. But, you know, despite the increased healthcare needs that I just mentioned that individuals on the spectrum have, they are more likely to have unmet needs in terms of receiving necessary services. And so access to services has been noted to have a significant impact on health outcomes, and quality of life. So those health and health outcomes and quality of life are impacted by all of those barriers and all of those structural inequities. And so for some, that can be very damaging to their health and health outcomes and quality of life. And so we know it's really important for them to access services. We know that they have increased needs for services, yet they have unmet needs. And so, and yet we know that they also have this inequitable access to services. And so we'll talk today about why is that and what can we do about that. So I really like this picture depicting what are the differences between equality and equity. And so when we say equality, it means everybody's equal. And so they don't really account for the individual differences or the increased needs that somebody may have or the barriers that somebody may be encountering. So in this picture, equality is it's all of these individuals are equal. They got the same bike. And so she may not be able to ride a bike, and he's too tall for a bike and is very uncomfortable riding this bike. And then this one actually works for this person. And then this child is obviously far too small to ride this big bike. So equality is everybody gets the same, but sometimes that's not enough for certain individuals that have all these barriers and challenges. And so equity is where we want to shift our conversation towards, is that you can see that they've made accommodations for this person to be able to ride this bike. And this is a taller bike and a medium and a smaller bike. And so equitable is something where we can talk about how can we enhance people's access to equitable healthcare, and that we're accounting for some of those barriers that some individuals need a little bit more than others, or some people need different services than others. I'll pass it to you, Jennifer, if you want to take it.
Okay. So when we're talking about autism and the disparities in autism, a disparity occurs when a health outcome is seen to a greater or lesser extent between populations. Some populations are experiencing many more health disparities across the board, and certainly that is also the case when we talk about autism. And really, despite the increasing prevalence of ASD in the general population, 1 in 44, disparities are still existing among specific groups. And they exist, as Susan said, there are many groups that we could talk about when we're talking about health disparities. We're going to focus tonight in our presentation on racial and ethnic disparities, but folks will have disparities because of cultural practices, because of socioeconomic status. They may have health disparities and health outcome differences because of their geographical area. Parts of the country as well as rural versus urban. Because of gender, there can be health disparities, and certainly because of sexual identity. And ASD occurs across all racial and ethnic groups. So we're talking about a condition where we see individuals within all race and ethnic groups showing symptoms of autism. And data suggests that ASD is more common in white individuals. But consider the impact of underrepresentation in research, in media, and medical education, and clinical spaces. The disparities are disproportionately affecting specific racial and ethnic groups. And this results in differences in diagnosis. Certainly it results in differences in the age of diagnosis and or misdiagnosis. Every time we see a new report from the CDC, we are seeing that the gap is beginning to close, but we still see that there are tremendous differences in the age of identification and diagnosis. As we often hear when we're talking about this around early detection and identification, is that if we think about the impact that autism has on the growth and development of young children, as they're growing into the selves that they will become, disproportionately, individuals who are Black, African American, and Latinx are diagnosed later, meaning that all of the interventions that they could avail themselves earlier, early interventions that we think are making a difference in brain development, are not as available to them, and may mean that they are disproportionately affected by difficulties with cognitive status, intellectual disability, severe behaviors, less capabilities in the area of adaptive behavior. They may have less access to services. Certainly support services have not been made as available if folks are not clear about a child who is Black, African American, Latinx having autism. It's going to make the transition to adulthood and what's happening in adulthood more difficult, especially if an individual has gone without a diagnosis, gone without intervention for a longer period of time. So the impact that it has on early diagnosis is this lifetime consequence for individuals on the autism spectrum, that early diagnosis and access to services, we now really believe is a key to better outcomes in the area of autism, but possibly better outcomes in health outcomes, because autism can also present a barrier for individuals in accessing health services. Children from racial and ethnic minority groups have historically been underrepresented amongst children who are identified under the age of 3. They're missing those critical developmental periods where interventions can make a really big difference in the social communication and language and communication skills that are seen lagging very early on in development. And children who have delays in social communication and language, those delays are linked with more intellectual and developmental delays. We certainly see worsening restrictive and repetitive behaviors and delayed adaptive behavior. Data is showing that white children are more likely to be diagnosed with autism spectrum disorder earlier in childhood than Black and Hispanic or Latinx children. And this is negatively impacting the earlier interventions that children can receive for health and education, for behavior management, behavior modification, training in social skills development, therapies like speech, physical and occupational therapies, and cognitive-based therapies. And the data suggests to us that on average, Black children receive an ASD diagnosis 1.6 years later than white children, which makes a difference. We already have struggles with getting children diagnosed at an early enough age to feel that they are making use of the services that are available to them. It's estimated that only 20% of children who actually end up needing services are receiving those services prior to the age of 3 through Part C. And many, many fewer of those children are Black and Latinx. Additionally, Black autistic children encounter 2.6 greater odds of an incorrect diagnosis. They're 5.1 times more likely to be misdiagnosed with an adjustment disorder. They have 2.4 greater odds of being diagnosed with a conduct disorder and are more likely to be hospitalized in psychiatric units. And this is very important because when we make misdiagnoses, we tend to see that some of these diagnoses, conduct disorder is a very good example of a diagnosis that instead of getting an appropriate diagnosis of autism, a child might get a diagnosis of conduct disorder, which is in and of itself a heavy-duty psychiatric diagnosis and requires a very different kind of intervention and would very much be the wrong intervention strategies for an individual who has autism.
So my background, partly as a qualitative researcher, just really appreciates the context that a quote has. And so these are some quotes that we had from focus groups from families that said, they'd just be thinking like, oh, he's just a bad kid, or you're not doing enough with your own to teach them this, whatever. And so it's apparent. And so that's what one mother of a Black autistic young adult had said, that some of the structural racism that they've encountered in their path. And then another person was just very thankful, saying, I'm thankful that you're here listening to us, because I think by sharing, that's how we make this more visible and letting the parents' perspectives be known. So we found these quotes to be really helpful and supportive of everything and really provides a parent perspective.
I think that when we think about a parent's perspective, parents are really, they're trying to discern the very best of what's happening with their child's development. And it's really quite concerning, this 3-year delay between the time when parents of Black children report concerns to a healthcare provider to the time when the child actually receives an ASD diagnosis. It is concerning to us already that there would be a delay at all, but the fact that this is so pronounced for Black children, and these delays can really be a structural and systemic racism. Recent research has noted that Black children with ASD to be significantly more likely to have an intellectual disability compared to white or Hispanic or Latinx children with ASD. And the presence of that intellectual disability is almost 50% of Black children diagnosed with ASD. It's alarmingly high compared to white and Hispanic or Latinx children. And if I'm not mistaken, some of this is coming directly from an article that was recently written, and Dr. Saulnier is one of the authors on that article. We also know that there's a sizable impact on cognitive impairment as a result of a delayed ASD diagnosis and access to services. As many of you know, so much of the work that we are doing with very young children is identifying how early autism may begin to unfold. And it's having an impact on early brain development, which we know is growing by leaps and bounds in the first 3 years of life, really in the first 18 months. And so an early diagnosis allows a child to get the intervention they need to realize the significance and the importance of verbal communication, social communication, recognizing the world around them, and can potentially impact on their overall outcomes as they move toward their school age years in terms of intellectual abilities and abilities to be adaptive in the world around them.
So those were some of the areas of highlighting the racial disparities specific to Black individuals that they've encountered. And so we also wanted to highlight that there are ethnic disparities that are encountered by our Hispanic or Latin population. And so some of these include the children not getting a timely diagnosis or an early enough diagnosis. And so and then accessing those services that are recommended that can help improve some of those other areas and within domains of autism. So these barriers to our Hispanic or Latinx population include provider discrimination. So families feeling that the provider is discriminating against them. It also includes stigma. And so there's a lot of stigma that's associated with the diagnosis of autism for some of these families. And so that's something that they encounter differently than other populations. The lack of access to healthcare services due to non-citizenship or low income or low socioeconomic status is something else that often comes up in the literature, is that if families are lacking citizenship or are fearful of that citizenship, then they're less likely to access healthcare services. And when they're less likely to access those services, then that is going to have some significant implications on their health and their health outcomes. And then is similar for the low income, is that if they are unable to afford some of these services or have access to them through that, that's also going to impact them. When families, when they are not speaking English as their primary language, there's a lot of difficulties that are encountered in between providers and that translation between what is needed and next steps. So the non-English primary language also can serve as a barrier for some of these families. And then lack of provider representation is something, and I know Karen's going to talk a little bit shortly more in depth on ethnic disparities, but these are just a few of the things that the families that are Hispanic or Latinx are encountering. And so when you don't see yourself in the provider in which you're seeking care, how that can be discouraging to some families, and that can reduce their access to services for that very reason. And so as a result of those, Hispanic or Latinx children are less likely to be diagnosed with ASD compared to white and even Black children. And so they're going to have a later diagnosis and less likely to be diagnosed. And then also as a result, we see that Hispanic or Latinx children with ASD are more likely than white children to have lower IQ scores. And so thinking about the need for services or access to services and the impact that has on IQ. And studies also suggest that Hispanic or Latinx individuals are less likely to have usual sources of primary care. And so they have lower healthcare use, including mental health care, which is so critically important, as we saw on those co-occurring conditions at the beginning, compared to Black and white individuals. And so so without a usual source of primary care or a medical home or somebody to go to regularly, and or that decreasing access to mental health care is going to have a significant impact on their health and their health outcomes. So let's talk a little bit about that, of what does a delayed diagnosis and what are the downstream effects, or what are the impacts this has on a patient's health or an individual's health. And so studies have found that Black and Hispanic or Latinx autistic youth and young adults experience greater adversities when encountering healthcare systems. And so we talked a little bit about some of those adversities to engaging with the healthcare system. And so those differences and that quality access and that quality care that they're not receiving have resulted in disparate psychiatric and physical health outcomes. So when compared to the general population, research suggests that autistic adults have higher rates of physical health conditions such as hypertension, diabetes, epilepsy, skin disorders, and endocrine disorders. And so they're encountering these conditions more often than a neurotypical individual is. So they have higher increased healthcare needs. But from what you've heard all along is that they also have greater adversities to getting access to quality or care at all. And so these are some surprising statistics, but something that needs to definitely be discussed is that our Hispanic or Latinx autistic adults have higher odds of obesity, diabetes, hepatic disorders, high blood pressure or hypertension, vision difficulties, headaches, and cardiovascular or heart disease. And so this is something our Hispanic or Latinx autistic adults experience more than white autistic adults and Black autistic adults. And then the research looking at autistic Black adults has found that they also have higher odds compared to Latinx or white individuals on spectrum, and those include high blood pressure, diabetes, obesity, asthma, and they're more likely to be hospitalized for cardiovascular disease. So these racial and ethnic disparities have also been found to exist. Not even those are the medical conditions that are impacting these individuals, but they're also found to exist in psychiatric conditions among autistic adults. And so we see that there are higher rates of a psychiatric diagnosis, such as schizophrenia, in Black and Hispanic or Latinx individuals compared to white individuals. And then particularly to Black individuals, the data suggests that they have higher rates of drug abuse or dependence. And so researchers note that these disparate conditions may reflect inequities in access to quality mental health care for Black and Hispanic or Latinx adults with ASD. So if they're not accessing psychiatric support or quality mental health care, then they are going to more likely have more conditions, and they are going to often have more severe symptoms as well, because they don't have access to quality or the quantity of the services that they need. And so we talked a little bit about the health in terms of their physical health, but I think something that's also often overlooked is the safety and the impact safety has on somebody's health, not only physical health, but also psychiatric health. And so on their health. And so the impact of a person's safety has significant impact on their physical and mental health. Is that if somebody doesn't feel safe or they are in harm, that has a significant toll on their physical and mental health well-being. And so what we've seen, especially more recently, but we're learning that many law enforcement officers really lack adequate training in recognizing characteristics of autism, and they may interpret certain behaviors associated with autism as actions that are threatening or suspicious. And so things such as avoidance of eye contact, difficulty with social communication, repetitive behaviors of rocking back and forth, and the sometimes the urge or the attempt to leave or elope a scene, which are all things that can sometimes happen with autism. Those behaviors, particularly in Black and or Hispanic Latinx individuals, are often seen or misinterpreted as threatening, and that can have a significant impact on their psychiatric, their physical health as well. And so as a result, because the law enforcement is unfortunately and many times not adequately trained, that results in physical and psychological harm, and in some cases, unfortunately, even death for individuals on the autism spectrum, but particularly those that are Black and Hispanic or Latinx. And so statistically, they find that by the age of 21, 20% of individuals on the spectrum have engaged with law enforcement, and a quarter of those have resulted in an arrest. And young Black autistic males particularly are 7 times more likely to encounter law enforcement officers. And compared to white males, young autistic Black males have been found 3 times the likelihood of being killed by a law enforcement officer. And so these have some serious implications on the health of individuals, and certainly we'll talk about ways in which we can shift this discussion of what can be done. In a recent study, 15% of law enforcement officers indicated they used physical force, and 25% indicated that it resulted in an involuntary hospitalization for that person on the spectrum. And so these findings are extremely concerning, and definitely an area of focus that needs to happen, where we can work to improve these outcomes and these odds through training. And again, I just think it's really important for us to share it from the actual perspectives of individuals. So a couple of years ago, actually by now, we hosted a panel through Emory School of Nursing and through our partnerships to host an Autistic Black Lives Matter, where we had several advocates that spoke up, and through ASAA. And so here's what our advocates had to say, is that in some instances, I feel afraid for my life. And another said, for me to be safe, I usually have to have somebody with me. Like if I go to a store, usually my mom or my dad outside in the parking lot, I usually have my phone, or when I'm with friends and stuff, I usually have to have somebody with me at all times. And another person said, for me personally, being Black and autistic is often misinterpreted by some law enforcement and security personnel. For example, on the airports, TSA, they're training to pinpoint certain nonverbal behaviors that may be deemed suspicious. I've experienced being misunderstood in that regard. So I think these quotes are really representative of the ways that they have encountered law enforcement and others, such as through TSA, and how this takes its toll on their physical health, but also their mental health and well-being as well. And then these were just a few other quotes. And I know the one on the left is really small, but I couldn't find myself a way to take part of the words out because it was all just too powerful. And that the individual says, my mother is fearful that I may get harassed, especially what has happened this summer. I would say with the unfortunate instances of Black men or Black men being assaulted and killed by the police, she's very fearful, and I wouldn't know how to handle myself in those kinds of situations. What I do is I remain in constant contact with her. I make sure that my phone has enough power so that I can call her if I'm out somewhere. And if I feel nervous or unsafe, I just go home. That basically is how I cope with those kinds of situations and those thoughts. And similarly, another individual had said they set themselves for me, they set my personal curfew. I have to be home around 10 or 11 o'clock at the latest. I don't feel safe after that time. Every time I see a police officer, I act differently around them because I don't want them to be suspicious of me. It's just something I'm just really, really cautious about. And then lastly, the biggest fear somebody says I have is whenever people are saying that I'm being suspicious that the police would be called on me, then it can escalate into something where my life would be threatened and I or another Black person can be turned into a hashtag. It's always a constant fear. So I think we hear that theme of fear and the concern for their safety and their security and how that takes its toll on an individual's health. And so I think, where do we go from here is that we really need better education of healthcare providers and law enforcement. We need to have better and enhanced media representation so that others are aware of what the different parts of the spectrum, but what that looks like across different races and ethnicities. And greater diversity in research participation, including having individuals on the spectrum and driving the research and contributing greatly to that conversation. And then identification and removal of barriers to enhance equity. And so I think Karen would like to contribute specifically to the disparities discussion.
Yeah, I'll make mine a little bit shorter for the sake of time.
I just want to introduce you, Karen. You're very special. So I'm sorry I didn't. Let me just refresh your memories for those of you who've been listening. Susan Brasher was the main speaker, and you just heard. She's assistant professor.
We can no longer hear you, Leslie.
In the Department of Pediatrics at Emory. Oh, that's weird. Oh, it suddenly froze. Yeah, I froze. It's frozen. I'm sorry. Anyway, just to refresh you, Jennifer Staple-Wax, Associate Professor, Division of Autism and Related Disorders in the Department of Pediatrics at Emory University, and Karen Guerra, who you'll hear from right now, who's the bilingual speech-language pathologist, also at the Marcus Autism Center and Children's Healthcare of Atlanta. Okay, Karen, take it away.
All right, thank you, Doctor. It's really lovely to be here. Thanks everybody for joining us. I know it's for some of you it's after work, so we really appreciate your presence, and I'll take it away so we don't take too much time, and we have some great speakers on this panel, so I'm excited for the other talks as well.
And we have extra time too as well. So
okay, all right, good. I'm a fast talker, right? Fast talker over here. Okay, can y'all see my screen? Yeah, yes? Okay, and you can hear me okay? All right, thanks. So I thought I'd start a slide with this sort of terminology reference. Some of you might have heard a lot of these terms, or maybe just familiar with one. At the end of the day, and I have another individual who can also weigh in, Samuel Fernandez Carriba. You heard Dr. Brasher mention the terms Hispanic or Latinx. And I think just for the purpose of this talk, I'm going to use Latinx or Latino, but I thought it'd be a good review to mention that a lot of these terms are used to describe ethnicity in the Latino, the Hispanic, the Spanish speaking, the Latinx, the Latin community. And I want to say that a new term to me, as I was reading Dr. Andrea Zuckerman's, let me move all the little faces to this way. Okay. As I was reading Dr. Zuckerman's article recently, the bottom, you're going to see the term Latin. And so Latin is a gender neutral term that is more easily pronounced in Spanish than Latinx. The term Latinx really is just, to me, it speaks more about inclusivity. And I know that within ethnic and racial disparities, we also have this idea of a lot of intersectionality. And you know, at the end of the day, I think folks are going to refer to themselves in a way that they feel comfortable. But for my purposes, I moving forward, have been using Latinx myself to refer to others, to myself, to our community. So I'll leave you with that. And also, when in doubt, just ask folks, right? I think that's always helpful. All right. ¿Cómo se dice? ¿Cómo se dice? Go my slide. Okay, there we go. So as Dr. Brasher and Dr. Staplewax covered in their amazing talk, we know that these racial and ethnic disparities exist in early identification and treatment of autism spectrum disorder, particularly among Latinx and Black children and families. Because of my expertise in my line of work, I'm gonna strictly focus on Latinx communities and gear more towards earlier than later, but we know that these ethnic and racial disparities do exist across the lifespan. For example, so going back to the earlier years, we know that Latinx children are less often diagnosed before the age of 4, as Dr. Staplewax mentioned. In fact, Latinx children are sometimes diagnosed up to 2.5 years later than Anglo and Black children. And the gap recently just, Black and Anglo children are now being diagnosed more or less about the same time, but it used to be that Black and Latinx children were later diagnosed. And so that's the hope, right? That in the work that we do, that we can continue to also narrow the gap, not only for Latinx children, but for other children from other ethnic and racial communities, excuse me. And so again, just some studies, again, from Dr. Zuckerman, she really highlights this idea that, you know, when they took a deeper dive into what was some of the disparities with the Latinx communities and ASD, they found that Spanish-speaking Latinx families have the lowest weekly therapy hours. Okay, myself as a clinician, that's really important. We know that frequency, we know that contact with your early intervention provider is really important, but it's not only the amount, it's the quality, okay? And that quality, what I mean by that is, it's also having those relationships with the provider and building upon that trust to achieve better care. And so again, Spanish-speaking Latinx families have more unmet therapy needs than children who are English proficient Latino families or children who are non-Latino white families. And so while there are many, many significant needs, for the purpose of my 10-minute blurb, I will just focus on 2. And we are gonna mention, I'm gonna talk about a little bit of the impact of lack of information or ASD knowledge in Latinx communities. And then also this idea of healthcare system navigability, specifically as it refers to families accessing services interventions. Dr. Staplewax also spent some time talking about this. And so we know that in several studies of Latinx families, of children with ASD, lack of information continues to be a theme that keeps popping up, okay? And that lack of information creates a barrier, a big barrier for these families in terms of service use of interventions, but also, again, of the quality and the quantity of these interventions. we've also learned that mothers with greater social support have shown improvement, improved engagement, greater frequency of verbal praise, and heightened sensitivity during mother-child interactions. And this study was done by Lauren Sissick and her team, I think, 2015. This is a picture of a parent support group that I got to, actually this was parents participating in a study that I conducted with Dr. Lindy Morgan and Dr. Jennifer Stapleback at Marcus Autism Center. And so I just wanted to share a testimonial from one of our caregivers. Just like Dr. Brasher, it's really important to hear from the families and what they have to say and how, what they think of these studies and what they learn, right? So I translated this. I would have had the live audio, but I didn't want to push everybody's Spanish skills at this time. So Lupe, we call her Lupita, after participating in a study that was by a bicultural bilingual individual who took into consideration the culture and their needs. She said she felt extremely grateful that we took account her community and providing great support in Spanish. She's also grateful for sensitivity and empathy Karen uses in sharing information and teaching us tools on communication. Another big piece that we found was that some of these families, you know, they may have had a general sense of a child's communication skills, when they should say their first words, maybe when they should start combining words, but they really didn't have a great sense of that communication as it relates to social communication and engagement, right? So what is joint attention? What does joint attention look like when my 10-monther or 12-monther initiates it, okay? And Lupe also said that the study CITAS, excuse me, can help future generations of parents learn more about the how parents can connect and interact with their children, or to detect possible problems in language and behavior, especially at a younger age, so that they can enjoy a better quality of life. 1,000 thanks from my heart. Thank you, Karen. And then Clarissa was a fellow or research coordinator helping us out. She was also Spanish speaking and she was from Peru. And so it was really touching to learn and to hear this from the families, mostly because they felt they had a second chance. Some of these families already had an older child on the spectrum. And, you know, it's just one of those things like, if we could do it again, if we could do it again. And so I really appreciated hearing the value of what CITAS meant to them. And so this was in 2018 and 2019. And then I felt like we just took a pause, right? The world just took a pause in 2020. Just COVID hit and a lot of work just went on hold. And so moving forward to 2021 and 2022, I'm excited and encouraged to see that the work continues. And so I'm gonna just highlight a couple of projects going on at the Marcus Autism Center. And I know there are others in our community as well. And so this is a grant I'm involved in, led by Dr. Catherine Bricard, looking at a parent-mediated intervention for Spanish-speaking Latinx families at Marcus. And so this is using Project Impact. And we look at, again, as you can read on the slide, we look at parent empowerment, efficacy. We look at child social communication skills. We're also looking at ways of how we can continue to culturally adapt the manual. So the manual was translated in Spain to that Spanish. And so as you can read below, those are some of the other aims that we have. We also have, man, this little thing, sorry. Okay. So we also have another project currently going on, and this project is looking at utilizing the diagnostic Odyssey interview to evaluate feasibility and acceptability of this measure and identify characteristics that may be more predictive of delays, and also to basically give us information on what more increased barriers to services within the Latinx community. And that's Dr. Picard, Dr. Klin, and Adriana Mendez. Another project, right, guys, how am I doing on time? Okay, yeah.
You're good with time, Karen. Carry on.
Thank you, Dr. Rubin. My timer. Okay. All right. The second project that I learned about being led by Dr. Stormy White and her team, Dr. Clayman, and others. Sorry, I'm gonna keep this. The little faces keep moving on my computer. I'll make it work. I don't know what's going on. So this project is from the SPARK. It's a SPARK study, and this one is looking again at helping address disparities, not within the Latinx, but right now, but with Black communities. And they're looking to increasing recruitment of Black children with autism spectrum disorder and their families. They're also looking on how to provide more culturally relevant outreach activities by gaining knowledge from community members about such topics as barriers to participation in research, areas of clinical need, perceptions and misconceptions of autism spectrum disorder. So again, just really encouraging that these projects are really helping drive the work to get this information out to our families, but then also to help us learn as providers and as researchers, what do we need to do, right? And so we know that a lot of times in research, we provide parents with these parent questionnaires that haven't been normed with their population, with their group. And so if we really are trying to look at what are your specific needs of your family, of your culture, I think it's really important to focus on these culturally relevant and culturally tailored interventions, but also tools to help us learn more about these communities that we're serving. So I'm going to actually wrap up pretty soon. I just wanted to kind of go along too with what Dr. Brasher and Dr. Staplewax had in terms of like, well, what's next? Where do we go from here, right? So, I mean, I feel like as a whole, our group is really driving this work, and I'm really humbled and grateful to be part of Break the Cycle, mostly because we are so diverse, and also mostly because I'm learning from them. I'm learning more about research. I would have never had a shot at research otherwise. So it's really a huge blessing to be part of it, because I feel like in turn, I'm able to give back to my community and to help other communities as well. And so what can we do in terms of a path forward? We can increase autism education and outreach to diverse families and professionals. We can equip EI, early intervention staff, with the ability to screen and develop trusted relationships with families. So train all staff on cultural humility if you can. We can train staff on least bias methods to help reduce discriminatory experiences of Latinx families and other families. And we can also train staff on bilingual development, right? And that's really important. I come across this every day, every week when I'm doing an evaluation and I have a family that perhaps well-intended pediatrician refers them, and family has potential concerns with autism red flags, but then their concerns are sort of, I wouldn't say not validated, but that they're being advised that perhaps they should wait to obtain a diagnosis, that it may be the bilingualism or the dual language exposure. So I think it's really important to train folks on this area of bilingual development, and what does that look like separate from autism and together with autism. Okay, and then in this one, it's again, as I mentioned before, develop screening and diagnostic tools that have been linguistically and culturally validated and normed for Latin or Latinx or Hispanic or Latinos populations. Excuse me, Magaña also in some of her work, and other researchers mention the idea of policy level interventions. So again, we're really trying to create these interventions be cost effective. So we need some policy action in this area so that we can reach more communities, more families in the city, in rural areas. Another one is increased recruitment and retention of bilingual staff professionals. Really important. I know some of you know how hard it is sometimes to recruit bilingual psychologists or bilingual therapists, or you name it. So it's important not only to recruit, but to retain, especially if they're from that specific culture that you're learning to expand research on. So someone that might be fluent in Urdu or Mandarin or what, we still need more tools in so many other languages. So by all means, this isn't just meant to be a focus on Latinx. This is just what I'm sharing from my experiences. And then lastly, increased representation of clinical providers and researchers, because representation matters. If I had a nickel for every time I sang We Don't Talk About Bruno with my little niece last weekend. But yeah, I love that movie. And I can imagine if there was a movie about a girl that looked like me at that age, I used to think I looked like Pocahontas and I was like, oh my God, I'm Pocahontas. But this is really what it's all about. So that's it. That's all I got, folks. Thanks so much for tuning in.
Thank you, Karen. Thank you so much. Thank you, Susan, and thank you, Jennifer. We're now going to turn our attention to Jennifer Singh, who is the Associate Professor of Psychology at the School of History and Sociology at Georgia Institute of Technology, otherwise known as Georgia Tech. And Jennifer has been the main driver and leader of this whole program of Break the Cycle of Autism Disparities. And I'd just like to put it into a context, and I think you must have picked this up in the previous presentations, that the struggles for equity in autism diagnosis and services are a reflection of, or a microcosm of, the disparities in our larger society, and all the recommendations that have been suggested to correct the disparities in autism diagnosis and services and support for families who are Black or Hispanic or Latin or from any other part of the world, represent the diversity of this country and our critical need to embrace the real spirit of health equity and inclusion, and in some way accepting and embracing and really dealing with our wonderful blessing of diversity. And I see Jennifer uses blessing and curse, so I'll let Jennifer Singh carry on.
Thank you, Leslie. Thank you all for being here on this spring afternoon. And I'm really grateful for the folks who are on this panel, because we've been working together before the pandemic, during the pandemic, and now post. I don't know what this is, but we're still here in the virtual reality. And so thank you all for being here. I wanted to share with you today just some work that I've been doing around the impacts of COVID among Black children with autism and their families. I'm going to engage with, let me see if I can go forward here. How do I go forward? With issues of blessing and the curse of the pandemic. And so, as many of you know, there has been massive challenges and disruptions for people with autism and their families due to school closures, due to not being able to go anywhere, financial. It's affected mental, physical, and familial domains. These are just some highlights, from the news of how COVID is making daily life challenging for those with autism. Virtual learning has done nothing, is not effective. How teachers with special needs are particularly struggling and feeling helpless. But there is a little silver lining in how having a child with autism helps me ride out the pandemic. And so, these are some of the things that I want to highlight. We did a literature review before starting this project, and one of the things to think about in the context of COVID is that ethnic and racial minorities have experienced greater vulnerabilities to COVID in terms of exposure, in terms of death rates, and the like. Women also have had higher health outcomes. This could be due to labor, just gaps in the labor, or the fact that women do more service-oriented work. And then, there are challenges in rural and remote teachers where students face, different kinds of challenges. I mean, just the broadband issue is one of them. What we found, though, and I don't have time to go through it today, is that the current research really doesn't consider intersectional inequities. And so we're not only thinking about race, but we're also thinking about gender, also thinking about socioeconomic status, gender identity, and things like that. And, obviously there is limited representation in research, which is one of the themes that has come up so far. We also know that there's disparities across the board when it comes to Black children, more likely to be diagnosed with something other than autism, limited access to healthcare services, less likely to have a medical home, less likely to be represented in special educational programs, less likely to access community service and be referred to intensive therapy. And so the list goes on and on. Part of, when I was thinking about this research in COVID was really inspired by the work that I did, I have been doing with Dr. Leslie Rubin, interviewing families who cycle in and out of the autism clinic, which serves largely families who are living below the poverty line. The families I interviewed were, over 50% were single. These are single parent female families, relying on Medicaid. And over 70% had a child who identified as Black. And what I've come to realize is that there's many things going on here. There's social elements to barriers. There's the economic, and there's structural, right? And so when we're thinking about COVID, we might think of employment. Do you have flexibility in your job? What is your house like? For all of us who have been bound to a home, we know that having a bigger house was actually very nice, right? But what happens when you don't have that, or have the financial ability to pay for more food, or pay for more air conditioning and things like that, or even the internet? And then we could think of just even social support and how important that has been. So these are existing, barriers that existed before COVID, right? And so we need to think about how the situation was before and then now with COVID. And so when COVID hit, as we were all impacted, the only thing I could think about was, what are these families experiencing? What are they doing? How are they doing? And so I was able to interview 18 families. So these are caregivers during the summer of 2020, which seems so long ago, right? And I interviewed a few in the fall. And my most, I just really wanted to know, what's the social and economic factors, and what has been impacted by COVID. And I did a thematic analysis with the interview data. Again, looking at the family characteristics, very similar to our larger study. Where we have single parent households, families living below $40,000 a year, relying on Medicaid health insurance. And, one thing I want to point out is, some of the families I interview are grandmothers. And so they're navigating this in a very specific way. And, one of the families I love qualitative research. I'm a qualitative researcher. She said, COVID has been a blessing and a curse. And so I've, really been thinking about how this shift has changed things for families for the better, how we might reimagine new realities, but also, definitely thinking about how disruptions have really impacted individuals with autism as well as their families. And so thinking about school closures, in Georgia, obviously our schools were closed, and for families who are have less resources, the school offers the therapies. Oftentimes, that is their resource. And so when the school closes, it can be a curse. Parents talked about their concern their child is no longer having that social interaction. One of the things we talk about in sociology is sort of that hidden curriculum that happens in school. And so much of it is that social interaction, especially for the younger teenagers who are sort of learning this and really excited to be part of that. So they're no longer part of that. Few received individual education plans, this idea that they were literally being left behind. And, I think many parents understood the situation, but nonetheless, they felt that their children weren't getting what they, obviously needed. The online format was not optimal. Kids would tune out. There was, beyond the connectivity issues, being able to work that long with the computer, if it worked, was often not the way in which children were to interact. I mean, how do you do therapies online? Speech therapy, for example. The lack of structure, routine changes was obviously a big theme, and how that really affected children. And the parents' concern was that they were regressing cognitively, socially, and emotionally. And this was something very concerning. And this was, like a couple of months after we all the world stopped and we played the tune. I loved Karen's, pause. Even though our research paused, the lives of people did not pause. However, there is a lining here, a blessing. Families talked about how it was a break from their child getting bullied, right? And so they saw it as a relief where their child wasn't anxious about getting bullied at school. And so this is really concerning, obviously, that this is happening. Reduced anxiety because they didn't have to socially interact, or maybe they're sensitive to crowds and noises. And so the school environment wasn't optimal. And so being away from that was actually better for parents and their kids. Parents saw it as an opportunity to learn everyday life skills, cooking, cleaning, shopping, hygiene, things that often get overlooked because we're so busy, that this would be part of the learning at home. And then one mom talked about how it really helped students, or helped her son think about future work skills, because a lot of our work is done with the computer. So this was a new way to learn some executive functioning skills that would help him with planning, scheduling, working with the computer, and really a time to catch up. The world stopped, and so parents saw this as a way for their kids to catch up academically, cognitively, and the like. And so these are some of the blessings and the curse. A second sort of domain I'm really interested in is employment and how parents are dealing with this. Certainly shifts in employment were challenging. I forget what percentage of my participants did lose a job. It was about 50% lost. One person in the family lost a job because of COVID. But there was a blessing in terms of those who had flexibility in their job, especially important for single parents, that could reduce their hours so that they could spend that quality time with their child. Parents talked about how it forced them to reconsider what they had to do. And so maybe they quit their job and did something different. And then that in a way created a better environment for their home altogether. COVID freed me was the way in which she described it. However, one of the things that we see is that parents are taking on more and more responsibilities, right? Not only are they the parent, and the caregiver and, doing all the work that they do, but now they're the teacher. Our house is turned into a schoolhouse. The liaison, even more so between teacher and child, and special educator. They're coordinating activities that they can actually do. Obviously it's gotten better. You have to remember this is in 2020 when I interviewed these families, or, they're trying to do the best they can doing remote therapy and the like. And so part of the interview was also just to really discuss the current moment at the time and thinking about not only the COVID pandemic, but the pandemic and the long durée of racism in the United States. And, this is something that was definitely on the minds of the families that I interviewed. And to echo the work that Susan shared with us in terms of the fear parents have for their child. The police don't know about mental issues. And so the concern that their children might be interpreted differently, not only because of their autism, but because of their race and because of their gender and because of their age, and so there's multiple intersecting forms of identity that are shaping how people are interpreting their children. So there's definitely fear for their children and their safety. They also talked about the difficult conversations that they were having to make, and how it's this ongoing conversation that that's unresolved. It's one thing talking to your child about being a male, and then another talking to your child about being a Black male, and then you're a Black male with a disability living in America. And so, these are constant conversations that parents will talk about, that they have to have with their children. And then that involves educating their child, providing scenarios, right, of what it means to be Black in the United States, teaching different ways of coping. How do you interact when you're, you can't act a certain way because it can be misinterpreted or interpreted as something other than what you're experiencing. You're not going to harm somebody, but not everybody will know that. And just the idea that it's so difficult to teach children with autism about racism. And so I think these are really important things that we need to consider when we're thinking about how people are experiencing this moment. I just want to conclude and to say that the intersecting inequities based on race, social class, gender, disability, the longstanding forms of racism in the US really must be considered to understand the impacts of COVID-19 among Black children with autism and their families. And so we really need to think about these intersecting forms of inequity together if we're to really understand it. And I'll end with a quote. We're already, and this is from my mom, who's just explaining how overwhelmed this situation is. We're already fighting tooth and nail to get services for our kids when there wasn't a pandemic. And now, how do we fight our IEPs and everything through a pandemic to get what we need versus just being at home and trying to teach our child when you're not a teacher in school and feeling, is this just going to be enough? And so my hope is that I can follow up with these families and see how they're doing, because if COVID is not over, and some of these kids have graduated from high school, I hope. Thank you to participants, my collaborator, as well as students who worked on this project.
Thank you so much, Jennifer. For those of you who are in the audience, we will have time at the end for questions. We'll have lots of time at the end for questions. So don't go away, keep your questions going. And we're moving on to our next speaker, who is Teal Benavides, Associate Professor, Department of Occupational Therapy at Augusta University. Dr. Benavides is going to talk about geographic variations in public benefits for adults on the autism spectrum. Teal, it's you.
Thank you so much, Dr. Rubin, for that kind introduction. And hello, everyone. I'm humbled to be following such wonderful speakers. I really enjoy this team. Everyone is doing really important work, and I just want to acknowledge the comments and discussion that's going on in the chat about the very real life struggles that people are having accessing services and supports in healthcare and in education. And I just want people to know that in addition to the research that this group is doing, that we are all very much advocating on behalf of the autism community, in addition to the research, to try to understand better about what is going on. So I do want to acknowledge the very real challenges that continue. My name is Teal, and today I'll be sharing with you some work on trying to understand racial and ethnic disparities that exist across the United States that use a very large data set of Medicare and Medicaid individuals, adults on the autism spectrum. I also want to note that I might revert to identity first language and use the term autistic adult, which is what I tend to use in collaboration with my autistic research colleagues. And so I do want to acknowledge that when I use that, I'm not doing that in an offensive way, but I want to recognize the identity that many adults on the spectrum prefer identity first language. So today I'm hoping to share with you some emerging data on disparities and systemic inequalities that exist across the United States in those who are enrolled in Medicare and Medicaid services. So we've already heard today about what a disparity is, and just briefly, it's an observed statistically significant difference in outcomes between socially distinct, vulnerable, and less vulnerable populations that are not explained by somebody's needs or selection for a particular study. And today, the study that I'm going to be describing is all people on the autism spectrum who are for Medicare or Medicaid from 2012. And so this is not a result, what we're observing is not a result of selection bias. This is not me picking people to be in a study. This is everyone that received Medicare and Medicaid services who had an autism spectrum disorder in this 2012 data. And so when we think about and talk about services for adults, we often visualize the service cliff. People receive services and supports up to the age of 21, primarily through school systems. But as we move into adulthood, people want to be able to achieve education. They want to have access to health services. They want to be able to work and have a meaningful existence, contribute to their community. They want to be able to live independently and in a clean and safe environment. And so we need to understand how all of the services and supports exist to support individuals as they move into adulthood and as they live their lives as adults and older adults. What's really critical is for many of these things to be successful is healthcare. Healthcare is a very fundamental thing, both mental and physical health is a very fundamental thing to well-being. And so in order to really get at disparities and underlying systems that contribute to disparities, we need to understand the types of coverage that exist to support health and well-being for adults on the autism spectrum. And we want to avoid being uninsured, right? So being uninsured does not come with any benefits at all. And so when we think about health insurance or healthcare coverage, there's only a few other options that people have here in the United States. There's being covered under an employer-sponsored healthcare plan or one that's purchased on a private marketplace. Those are eligible to people who have a job generally, or enough resources or income to purchase that. And that is not the case for many adults on the autism spectrum. We know that adults on the autism spectrum are underemployed or unemployed at much greater rates. And so that is not generally the most frequent type of healthcare coverage that people have. Further, Veterans Administration or TRICARE benefits for military individuals is also not a very common route for autistic adults to receive healthcare coverage. And so we're left talking about Medicare, Medicaid, and coverage that includes both Medicare and Medicaid coverage, a group that I'll call dual eligibles. So Medicaid plus Medicare are called dual eligibles, and that's one of the things that I'll be using today is that term dual eligibles. So when we think about these public benefit programs, the challenge is that Medicaid eligibility and benefits are affected by state policy, funding restrictions, and waiver differences across each state. So somebody with the same needs or healthcare priorities living in Georgia may not have access to the same services and supports as somebody living in South Carolina. And this is a problem because that means that people with very similar needs in the United States might have access to very different things because Medicaid is run primarily through states, even though they receive a share of federal funding. Medicare, on the other hand, has consistent eligibility criteria, but it is limited by its administrative burden. It's complex, hard to understand, and very few people know about how those under the age of 65 might achieve eligibility for Medicare and maintain that eligibility. And so we really need to understand what is going on to provide a consistent level of eligibility criteria to support adults across the lifespan. So we need data on who is eligible for these programs and how they become eligible, the pathways to eligibility. We also need information on how these differences in eligibility might exist across different states. Because we assume that Medicare has the consistent eligibility criteria, differences in eligibility for Medicare should probably reflect systemic inequalities. And that's one of the things we want to know more about, is understanding systemic racism, systemic inequalities, and barriers to programs that affect people in different areas. So the next couple of slides are going to share information and data that come from a data source produced by Centers for Medicare and Medicaid. It's called the Medicare Medicaid Linked Enrollees Analytic Data Source. It's a very long data source, and I'm going to call it MM-LEADS. The data that I had access to was 2012. A new data source was just released this year, and I haven't had a chance to purchase that data. So just to be aware that this data is about 10 years old. So the questions that we asked were what racial and ethnic differences are observed in eligibility for Medicare, Medicaid, or dual eligibility, and looking across the entire United States. And then we asked what racial and ethnic differences exist within each state for these public benefits. And again, we're looking at those who are Medicaid only, those who are Medicare only, and those who are dual eligible for both Medicare and Medicaid, with the idea that having dual eligibility allows people to have a consistent level of coverage despite differences by Medicaid in each state. And so we think that dual eligibility provides a certain level of maybe consistent coverage across the entire US. And so we were looking at whether there were similarities in each state by race and ethnicity for dual eligibility. So first, let me share that this research can be found. It was published late last year in PLOS 1. It is a publicly available article on racial and ethnic disparities and benefits eligibility. This first study I'm going to share with you included 172,000 adults between the ages of 18 and 64 years who met criteria for an autism spectrum disorder. These individuals were either recipients of Medicaid only, Medicare only, or had both Medicare and Medicaid. And this data included information about their eligibility, as well as health services use and costs of care. So who was in our study? We had, again, 172,000 people who were a part of this study, and approximately 70% were white. About 18% of our sample was Black. 2.5% of our sample was Asian or Pacific Islander. 1.5% was other or more than one race, and that included American Indian as well as Alaskan Native. And unfortunately, I need to make a note that the Centers for Medicare and Medicaid data do not distinguish race and ethnicity as separate variables. So unfortunately, we have race and ethnicity in one variable, and 8% of our sample was Hispanic. And these are the categories that are produced by Medicare and Medicaid. So we are asking for more clarity from Medicare and Medicaid on their racial and ethnic categories. But this is what we had to work with. I also want to point out that in the coming slides, that the analyses compare those who are Black and those who identify as white, as well as those who are Hispanic and those who identify as white. And that's because we were able to look at each state individually. For groups including Asian and Pacific Islander, which included about 4,000 individuals in the entire US, there weren't enough people in each state to be looking at those very specific racial ethnic differences in a state level. And same thing with other and more than one race. So we'll be presenting primarily Black versus white disparities and Hispanic versus white disparities. So first, I want to share overall across the entire United States what we found in terms of eligibility differences by race and ethnicity. Here in the blue, what we can see is the percentage of each racial group that was Medicaid only. These are people who only have coverage from Medicaid within the state that they live in. In the entire group, 172,000, a little less than 50% had Medicaid only. In the green, we have the percentage of each group who is both eligible for Medicare and Medicaid. And we had a little bit more than 50% of our total sample that was eligible for both Medicare and Medicaid who were on the autism spectrum. What is really important and very distressing is that Hispanic, Asian, Pacific Islander, and Black individuals were significantly more likely to be Medicaid only, meaning they did not have access to dual eligibility compared to white individuals. So white individuals were much more likely to have dual eligibility, have both Medicare and Medicaid, and racial and ethnic minorities were less likely to have dual eligibility. And these differences were really obvious primarily in later in life for the older adults in our sample when we looked at age and eligibility. So this reflects racial and ethnic disparities in who gets what, Medicaid only versus dual eligibility. And so we really wanted to dig into what this meant and understand it better. So this was all of the United States. What happens when we look at individual states? Among the people living in each state, are there racial and ethnic differences? And what we found is that for Black individuals compared with white individuals, that there were certain states in which Black individuals were less likely to be dual eligible. They were less likely to have both Medicare and Medicaid. That includes our home state of Georgia, which is a very dark red. That means that the racial and ethnic disparities were among the worst in the country. And you can also see here that Wisconsin also had very obvious racial and ethnic disparities, as did a number of other southern states and Midwestern states. And so what these differences show us is that disparities cluster in certain areas of the country, and we need to be thinking about local level effects or systemic inequalities that are driving these differences. Because eligibility for Medicare has the same consistent criteria across all of these states, what this is saying is there's something about the systems in these places that is preventing people from learning about or understanding possibilities for being dual eligible, or even factors that contribute to dual eligibility, such as employment or access to a job in which they can be achieving those working quarters for Medicare. When we look at Hispanic versus white individuals, we see both disparities and states in which Hispanic individuals are much more likely than white individuals to be dual eligible. The red and orange states are those in which Hispanic individuals are much less likely to have dual eligibility for Medicare and Medicaid. That includes our home state of Georgia, which continues to reflect really incredible ethnic disparities here, as well as some other states, including North Carolina, Illinois, New York, and others. There are a few states in which Hispanic individuals were much more likely than white individuals to have dual eligibility. And those include states out west, as well as Louisiana, Hawaii, and Florida. And so those states are reflecting a different pattern than what we saw in the previous slide. And so I just want to reiterate, what about other racial and ethnic groups? We didn't have enough data in each state to analyze Asian and Pacific Islander, as well as Native American and Alaska Native groups. One of my goals is that we'll be able to purchase more data and look at a larger group in more recent data that's been collected. And so future work will need to combine those multiple years so we have enough data to be looking. But we do know that across the entire US, those racial and ethnic disparities did persist, even despite the individual state level differences. So the main point, there are geographic variations in who is dual eligible for both Medicare and Medicaid by race and ethnicities. I also want to emphasize that people have talked about other factors that can contribute to disparities, and our data analysis adjusted for gender, whether a person had an intellectual disability as well as autism, whether they had different chronic conditions, what the county median income was in the county that they lived in their state, and whether or not they lived in a rural county. So these disparities persisted despite all of these other factors that we statistically adjusted for. So the next step is we need to understand why some states have greater differences in enrollment in these public programs. Some things that I can think of include systemic racism that perpetuates in how judges are ruling on disability status that might affect their eligibility for Medicare, access or knowledge about the public programs in specific states, and how that knowledge is communicated through the systems of care as people age into adulthood, as well as provider-mediated types of racism in which judges who are making determinations have specific, have certain views that affect disability determinations. So these are things that we need to understand better. So we need to understand system knowledge and how people know about these different resources. We need to evaluate systemic racism and person-mediated racism as factors that contribute to this. And then the next thing that I do want to acknowledge is we don't even know if dual eligibility is a good thing. We assume it's a good thing because consistent eligibility criteria and Medicare providing pretty much the same level of benefits across everyone in the US, no matter what your need is, means that we probably have more equality in who gets what versus Medicaid, which differs by state. But we have heard and know that people who have both Medicare and Medicaid have a hard time managing the paperwork that goes into it. And so maybe dual eligibility is a burden. So we really need to know more about whether dual eligibility is a good thing for people on the autism spectrum. So thanks so much. And I'm looking forward to our next presentation to wrap us up in any discussion and questions that people have.
Thank you so much, Teal. That was fantastic, bringing big data into this conversation and discussion, and also the underlying theme of discrimination and bias and racism in this whole discussion. So I think our last speaker is a fitting closer for this conversation, and this is Dr. Samuel Fernandez Carriba, who's a licensed psychologist and senior instructor, adjunct assistant professor, Emory University School of Medicine, CBCT. You'll have to tell us about that, Samuel. And he's going to be talking about the domains of structural racism in autism. Samuel, it's all yours.
Thank you everyone for being here. I'm really honored to be part of this panel of real experts. The presentation I'm gonna share with you is not my work. I just have the honor to represent the group of Break the Cycle of Autism Disparities. I'm gonna share my screen, and surely I'll tell you soon what CBCT is about at the end. And you must forgive me if I speak slowly or my accent is thicker than usual, but it's I think 12:30 midnight in Spain, where I am right now, hoping to return to Atlanta soon, but still here. which speaks about the wonders of technology and our new world. But without further ado, let's talk about these domains of structural racism in autism. This is work that has been going on for about 2 years that we hope to put in a manuscript and submit soon. Again, it's not my work, but I have the honor to present work done by my wonderful colleagues. My objectives then are going to introduce this group if you haven't heard about us, about our mission and our goals. Then describe briefly this model of domains of structural racism as an explanation of autism disparities. We hear descriptions on the topic of autism disparities, but much less, but more frequently, recently, an explanation on the underlying factors of why that may be happening. I loved Teal's talk because she was just going there. And then in line with the philosophy of this group that is made of researchers, but also clinical professionals, we want to offer a way forward, something concrete and tangible that could be done, hopefully, in addition to some of Karen's advice that she brought from Zuckerman's article. I'll make it very simple, talking about cultural humility and CBCT, cognitively based compassion training at the end. So who are we? This Break the Cycle of Autism Disparities group. I hope I didn't forget any name. I think Dr. Rubin already mentioned that we have the strong strong lead of Jennifer Singh, who together with Dr. Rubin, who doesn't know who Dr. Rubin is if you're in Georgia and work in anything that has to do with autism. Well, the two of them together, and Celine Saulnier and Susan Brasher, and then Teal, and then everybody else, including myself, Karen, Jennifer Staple-Wags here today, we all joined this group. And we are not only researchers and professionals, we were concerned with the world of disparities that we live in our state in Georgia, but nationwide and in the whole world. And we wanted to bring attention to this lack of equity in autism and work towards solutions to disparities, not only nationally, but also internationally. So our goals are not just to work with underserved populations, but to learn from them in the best spirit of cultural humility. We are both learners and servers, so we can really develop relevant research questions that will actually apply nationally and internationally. And these solutions have to be interdisciplinary. We aspire to disseminate whatever we find and we conclude, and to put it to work, to apply it to tangible solutions. It's a difficult topic, and I want to mention a word about the rich and complex conversations that we have had trying to assess, identify, and define this topic. You see here, well, there are social inequities. They are both the cause and the consequence of health disparities, mutually reinforcing. So it's not easy to separate what comes first and what is what. But as Frederick Douglass said, there's no progress if there's no struggle. So we are up to the struggle and up to the progress. We hope to make progress. Coming to the topic of this presentation, and facing the impact that social inequities have on autism practice research and the lived experiences of autistic people, we really hope to create a better understanding of the different factors contributing to autism health disparities, and then disseminate these again nationwide and internationally, so other professionals can build upon this framework and address ultimately disparities in autism. I was saying that there are reports on differences in race and ethnicity, but not so much on the underlying systemic barriers leading to these disparities. There was a recent commentary in the journal Pediatrics in 2020, well, maybe not so recent anymore, but issuing a call to action to investigate structural racism. We have had a little share of what structural racism is, but we are going to get deeper into that. I just wanted to point out that the emphasis of this presentation is on structural racism, and I'm going to dive into this model. We would appreciate any feedback about the model and the diagram that you're going to see next. But let's define first what structural racism is. It's a form of racial discrimination embedded in mutually reinforcing systems such as housing, education, employment, healthcare, criminal justice. We've seen examples throughout the talks today. The thing is that these systems actually perpetuate the discriminatory beliefs, values, and the distribution of resources, which ultimately shape different life experiences among racial and ethnic groups, and particularly in autism. So I was saying there are different levels of racism, and we are going to concentrate on structural racism here, but we recognize that they overlap and it happens at an individual level. That is racism, when someone really makes their own the racism that is present in society. It happens at an interactions level, personally mediated racism, when the interactions, the relationships among people are racist, and they happen in the systems, at a systems level, in a structural racism. This was the call from the journal Pediatrics, the issue to an action on this topic, but we recognize that systems impact relationships, and relationships impact people, and people in turn impact relationships and systems, and they all interact with each other. When we talk during this presentation about personal mediated racism, we're going to include persons level racism, because it affects persons and their relationships, but we will mostly address structural racism. And this is the model and the diagram about which we would appreciate the feedback. You see the three levels, the three circles, internalized, personally mediated, structural racism, and the three domains that also overlap. The boundaries are not so clear as we would like. They intersect, and they affect the three levels, and they are science and scientific knowledge, production, public policy, and social structures, and cultural understandings and representations. And it's all both the outcome and the cause of autism disparities. Although we tried to represent the outcomes in these squared boxes, and actually the hexagons would be ways to address these disparities, the way in to break the cycle. We are pretty happy with this diagram, but I'm sure it could be improved. Let's go a little bit deeper in each domain. The science and scientific knowledge production is the first domain that we try to describe as early research on autism, included primarily white upper and middle class children and families, and that had an impact on subsequent research, on research in genetics, research about diagnostic definitions, and research on tools and services and interventions. And it certainly overlaps with the other domains, because what we know about science, the science that has been done is going to determine the science that will be done. So it's going to have a profound impact on research funding and on whatever public policy is concluded from those findings. Also on the cultural understanding and representations, it's not hard to imagine that these biased research and some questionable methods so caused a profound distrust on the medical establishment, on professionals, on research. So it's all really tied together. We could go on, but let's move on to the next domain, public policy and social structures, which refers to the laws or policies that differentially impact racial and ethnic minorities, which are embedded in social systems such as education, health insurance, the criminal justice system that some of my colleagues talked about. The thing is that policies are generally shaped and determined by those who are in power, who are biased like all of us, but they are in power and have the power to actually create biased policies. And then stakeholders of diverse background are less likely to be involved. So that actually leads again to disparities in a system that is already inequitable. And I mean, there are things, laws that are biased to start with, but also there are social and historical factors that affect as well policies. For example, segregated housing is to some extent the effect of the 50s and 60s migration of middle class and white population to suburban areas in the cities of our country. And that actually concentrated areas of poverty in urban areas. So that actually, in a state and in a country that where public school funding is based on tax rates, that has a tremendous effect. And this is systemic and coming, from public policy and social structures, but actually impacted by science and having an impact on cultural representation. Again, it's all intersectional and impacting the three levels that we were discussing, although we are starting at the structural level. Then, I mean, there are more examples at a personal-mediated level. You can imagine if resources for education are scarce. You can imagine an adult or an adolescent looking for good transition planning with scant resources in their home county. If they have autism, if they have a diagnosis and they are part of one of those minorities, the resources are even more limited. So then let's go to cultural understanding and representation. which is what the wider community learns and understands, perceives about autism, largely impacted by scientific findings and by how the media actually presents autism, which generally is portrayed as a condition of white males in families of some level of privilege, which is the case for some, but unfortunately not for many. Just as a quick exercise, some of my colleagues in this group actually analyzed 52 movies, 52 films, and they found that 90% of the movies, in 90% of the movies, the autistic characters were white. In 73%, the autistic characters were male. 73%, they were played by non-autistic actors, and 71%, they communicated verbally. This is how the media is portraying autism, which is not accurate, and then actually leads to social inequities and autism disparities. So, of course, like the other domains, it overlaps with diagnosis, with science, with services, cultural representation and understanding impacts implicit bias in all members of society, including clinicians. And I've been doing diagnostic evaluations for almost 20 years now. And let me tell you from the bottom of my heart, how do I explain that when I see a child in clinic that is doing well at school, but has some social difficulties, the story changes in my mind if their father works at CNN and their mother is a doctor, or they come from rural Georgia. Again, no school delays, doing okay at school, but some social difficulties. Is it the parents demanding more eagerly in one case versus the other? Is it me interpreting that, you know, one child from Macon is okay? We all struggle socially. This is really something very real, and I wanted to make this point, bringing my own example, not to be too harsh. We want to do better, but if we want to do better, we need to be aware where we are mistaken. Also, somebody spoke about the criminal justice system and the challenge of being a Black adult male. If you have autism, you know that publicly exhibiting autistic behaviors puts you at high risk of police attention. So this is all cultural understanding and representation, autism, all mixed with all the examples that I've given from the other domains at the different levels. So what do we do? You know, there's room for pessimism, but some of us are optimistic at heart and believe that if there's a challenge, there's something that could be done. And we would like to present cultural humility as one way forward in breaking the cycle of autism disparities. There are other ways forward, and you know, expanding diverse leadership has been demonstrated. It has an effect on implicit bias in people, and that would come from directly from leaders in public policies. But what can we do? What can the clinician, the researcher, the autistic person, the citizen can start doing? And this is tough work, but it's something that we can all do starting right now. And it is working on cultural humility. Cultural humility focuses on the incorporation of a lifelong commitment to self-evaluation and critique, to redressing the power imbalances in the I'm going to say professional client dynamic. I'm going to translate this to my English. A lifelong commitment. You're dedicated for life to be more sensitive, to become more aware of yourself and others. And if you really, truly want to connect with others, you want to learn from them and you want to serve them, you want to be in touch with them. This is what I'm talking about cultural humility. It's a lifestyle. And it needs training, because we can have an inspirational talk, we can have an inspirational conversation and think, oh, we are done, I get it. And then go back to our daily duties, our behaviors, and do what we've almost always done. And this, to a large extent, is unconscious, it's implicit bias. So this training needs time, education, reflection, and effort. And I'm talking about a systematic training, and I'm talking about, yes, mindfulness, awareness of self, of others, and compassion training, the ability to connect, to serve and learn from others with others in a non-hierarchical manner. CBCT is cognitively based compassion training, that protocol that I didn't put on here. I didn't expect to speak specifically about it. But it's one mindfulness passion training in which I'm a senior instructor. And this is all. You can give us feedback at this email. Jennifer, thank you for leading us in this effort. This is our website, and this was our group before the pandemic, when we were able to meet and without wearing masks. I hope we'll be able to do that soon. Not everybody is in this group, but it was one photo that we had of nearly all of us. Thank you for your attention.
Thank you, Samuel, for a wonderful kind of wrap up to solutions to the challenges. And I think we were all very sort of touched by the cultural sensitivity issue and compassion and those things that help us to overcome and to break that cycle of health disparities. Our time is rather short, and I wonder if anybody has any pressing questions to ask of someone in the audience. There is a chat and there is a question and answer box, but the question and answer box has got like what shows people like. I'm not sure that's gonna match this, but I just want to say thank you to all speakers for today's presentations. It was rich and diverse and wonderful, and I think it gave us a lot of food for thought. There is one question that just popped up here, and it's for you, Samuel, and I'm going to read it. It says, have you factored in the impact of environmental racism in those communities and the impact?
Could you repeat the question? Have I impacted?
I'll give it a try.
Okay.
If you look on the chat box, Samuel, I think you'll find it. It's. I very much appreciate your focus on. Wait, Samuel, you got a lot of questions there, man.
Because I was last.
Have you factored in the impact of environmental racism in those communities?
I guess, we should define what environmental racism is. But I think we are talking, and this is really the challenge of this topic, knowing what we are defining, what we are talking about, because racism is the cause and is the consequence. Environmental racism can be structural, can be at the systems level because of public housing or public schooling. Sorry, or it could be at interactions level, environmental, because I'm from rural Georgia and I come to see this doctor in fancy Atlanta, or it could be at a personal level, and it could also relate to any of those domains. It could be, the cause of scientific knowledge, the cause of cultural representation, or the cause of public policies. I hope I answered the question, but I'll allow Jennifer to elaborate on that.
Yeah, I think, we hadn't really thought about environmental racism, but it certainly lies within the public policy and structure, because we do focus on residential segregation, which is often linked to environmental racism. So people with less power living in less resourced communities who can fight type of environmental damage that might be occurring in their backyards. But that is definitely an avenue to pursue, and something we want to do with this model, in terms of thinking about how the model can incite these new kinds of questions, and how we can think about environmental racism as it relates to autism inequities in terms of health, services, and outcomes.
We have 3 minutes to go. I'm going to just sort of take the liberty of commenting on two things. One is, I love that diagram, Samuel, and I wonder if you could just put it up again, that triangle diagram, because I think, I know it took a long time to come up with that diagram, but I think it is a very, very powerful diagram, that one. Very powerful, very inclusive, and I think it offers some of the challenges, and it offers some solutions. So I think I'd like us to take that with us. Secondly, I'd like to point out for those of you in the audience that the program Break the Cycle of Autism Disparities is part of a bigger program called Break the Cycle of Health Disparities, Inc., which is a not-for-profit that includes Break the Cycle of Children's Environmental Health Disparities, Break the Cycle of Environmental Degradation, and other cycles of injustices and inequities. So I'm going to just put in the chat box the Break the Cycle website for you guys to look at, and say that it is not up to date. It's going to be up to date soon, and so I hope that you will take an advantage of the opportunity to just look at the concept of health disparities in many different ways that impact all aspects of health. And in fact, I think it was you, Jennifer, who you were talking about sort of being Black and having all the disparities in health, but those disparities in health exist regardless of whether you have autism or not. They do health disparities that exist as a result of social and economic and racial disparities. So we're looking at the whole world of autism through that prism. So I just want to once again thank you all, and thank you, the Atlanta Autism Consortium, for hosting this wonderful panel, and wish you all a wonderful evening, and see you again soon, I'm sure.
And on behalf of the Atlanta Autism Consortium, Leslie and everyone here who contributed to this panel, you are outstanding. And I know that everyone benefited from this. And I just am so excited about that diagram, how well it was presented, and all the work that's continuing to be done. So thank you all so much. And for those of you that want to tune in next month, April 19th at 6:30, we have a neurodiversity panel, and it's going to be led by Carrie Magro and some other wonderful guests. So please put that on your calendar and help spread the word. So again, thank you so much, and have a good night.
Bye, everyone.
You all.